is when you look at countries where hydroxychloroquine or chloroquine is used liberally, and you compare that to data in countries where it's not used liberally. And for a discussion on that, I'm turning it over to Dr. Mitchell.
Thanks, Dr. Gold. My name is Jeff Mitchell. I'm from Ohio, and Dr. Gold and Dr. Emanuel just did a great job introducing what we're going to talk about here today. And I am going to use this little PowerPoint, and the reason is I'm going to talk about some numbers, and I'm going to talk about decimal points and lots of zeros, and if I just tell you that stuff, your heads will just spin. So we're going to talk about best outcomes, and this is one of the things we want to do. Chart that I'm sure you've all seen. This is the most commonly used dashboard produced by Johns Hopkins, and probably most of us in this room look at this thing several times a day, and you can get any country and how many deaths they have and that sort of thing. Well, this is another graph produced by Hopkins as well, and I don't think people see it as much, at least I don't see it on the news. And what you see up there in the purple is the United States having the most deaths, and this is current data. You can see down at the bottom, it goes into July. This is current data. So the United States has the most deaths in the purple, and down here the lowest in the white is India. But the thing is, India has what, 1.4 billion people? It's like 4 times as big as the United States. So when you correct that for population, India is even lower. I mean, this is dramatic. So when you correct for population, a couple countries are higher than the United States. And this is the best way to look at the data, is deaths per million people. And a couple countries actually are higher than the United States, and countries are lower, and India is way down there. So a lot of people started looking at India, and you've heard this come up several times. And that's how we first started to think about this. What's going on there? But I think India is complicated. It's huge, but it has a history of chloroquine that goes back to 1800. They're supposedly the world's largest manufacturer of hydroxychloroquine, and they've been using it. I'm not the expert on how much they're using it. Maybe other people know much. They're using it some. I don't know how much. They're using it for prophylaxis some. I don't know exactly how much. So it's tough to figure out what this India number means. So I looked at that, and one thing I knew about India with all this hydroxychloroquine is there's malaria there. And there's malaria in other nearby countries as well. But it's not like the malaria center of the world. So I started to ask, is there a connection? And Dr. Emanuel has alluded to this as well. There is a connection between malaria and the treatment of malaria and the treatment of coronavirus. And so we started looking at the other countries that have more malaria. And that's what got me thinking, and what led to the paper I printed. As it's long been used to treat malaria. We know India has it. But other countries actually have better outcomes than malaria. There are a lot of other small countries that weren't on that graph, and you're going to see in just a second, their numbers were way down, even lower than India. And they're just phenomenal. And so I looked at these 6 countries, and I picked these 6 countries because they're reported to be the 6 most malaria endemic countries in the United States. Wow. Excuse me, in the world, yes, thank you. The 6 highest malaria endemic countries. And they are Nigeria, Uganda, Mozambique, Ivory Coast, Niger, and Democratic Republic of Congo. So we decided to look at these and see what we could learn from that. And this is why we picked them. They have more than half of all the malaria in the world from just these 6 countries. And so we thought maybe, well, this will help. We'll get some more information from this. It turns out that these 6 countries have far better outcomes than India. And you saw in that first graph that India was so much better than most industrialized countries. So we looked at these countries to see if we could understand this and see what was going on. And so overall, this looked at 2.4 billion people worldwide. This is public data. This comes from Hopkins for the most part. And we looked at these countries, and what we found is that these 6 poor malaria endemic countries had fatality rates less than 1% of the United States and the industrialized West, which was actually Spain and Italy at the time. We found a very wide disparity in these death rates. These death rates per million population. And so 2 orders of magnitude means more than 100 times. And so just let that sink in for a minute. There's almost nothing else in science and in mortality rates where you're looking at a difference and it's more than 100-fold difference. Usually it's 10 or 20%, and you're trying to figure out if the study's big enough that you can really learn anything from it. But this difference in these death rates was 200 times, 400 times, 600 times. It was more than 100 times. And we're going to see graphs here in a second. And this disparity in these death rates is counterintuitive. It's backwards. It doesn't make sense. And all of you, if you're hearing this for the first time, you're thinking, how could it possibly be that those countries where they're so poor and so overcrowded and stuff like that, how can it possibly be they have lower death rates than the United States and the West? And so a lot of people just don't believe that data. And, that's okay. But we've got Johns Hopkins putting this data out every single day, and we believe their data. So how can a person sit there and go, well, I just don't like that data. It doesn't fit in with my preconceptions. That's not science. So if there's anyone that's not doing science, it's people that hear data and look at data and say, I don't know how to understand that, so I just disbelieve it. So actually, here's the raw numbers. And so I looked at, actually in the original paper, I looked at I looked at India, Bangladesh, and Pakistan as well, but I left that out for simplicity here. So you look at the numbers in the United States and Spain and Italy, and those 6 malaria endemic countries. And so we have the total population, you have the total deaths in the country, you have the death rate calculated as a percentage, and then you have the death rate converted to death per million, because you have to convert for population. And so the average at the time, at the end of April, beginning of May, the average I didn't put the average up there. We can do the math. But for the United States, let's talk about the United States right now. At that time, at the first article, it was 138 deaths per million. It's gotten worse since then, and you heard people talk about these numbers throughout the day here. A couple people have mentioned these deaths per million. It's about 450 now in the United States. And the average number of deaths per million in those 6 sub-Saharan African countries is 0.3. 0.3. So 1 person died out of every 3 million people in those countries. And in the United States, it was 138 or 461 out of 3 million. These are phenomenal numbers. No one's telling you about these numbers. What's going on in the world with these death rates? And there's the math. So I know it's hard to do math at a meeting like this or over the internet, but that's the same thing we just saw in the other graph. The United States, in the original paper, it's 138 deaths per million. Sub-Saharan Africa was 0.3 deaths per million. It's a ratio, so the death rate in the United States was 460 times greater than these countries in sub-Saharan Africa. This data was collected 2 months into the pandemic. And actually, so people come up with a lot of different things. Well, maybe they don't measure the data. Maybe they're lying to us about the data. Maybe they're reporting inaccurately. Maybe people just didn't go there. And we're going to talk about that in just a second. So people, hardly anyone thinks about this and talks about it. And when they do, they usually they make up their own excuses. The fact is, one of the ways I got started about this, I had a trip planned to Africa I was going to go the first week in March. So in February, I was looking at what's going on in Africa every day. My trip got canceled. And it was good, because if I would have gone, I would have got stuck over there and I wouldn't be able to get back. So that's how I got to be looking at what was going on in Africa. The pandemic started in Nigeria 3 or 4 days. The first index case got to Lagos, Nigeria, about 3 or 4 days before the first index case got to New York City. It actually started at the same time or even a couple days before. Now, here's a graphical representation of what we just talked about. So on the left, you have Italy, Spain, and the United States. And if you remember about that time, late April, early May, things were absolutely catastrophic in Italy and Spain, and not as bad yet in the United States. They got worse after that. And so here's these numbers just in graphical form. The numbers for Italy, Spain, the United States, 411, 465, 138. And these numbers, they're essentially zero in these other countries. They're not reporting any deaths at all. And the infection rates are way, way down too. When you talk about infection rates, the reason I don't talk about it is because you have to start talking about testing and how many people are tested and how accurate they are and a bunch of stuff like that. It gets confusing. But I think Dr. Simone, you said, and Dr. Emanuel as well, dead is dead. And when you're dead in almost any country in the world, they should be able to figure out if you died from coronavirus or something else. So these numbers are infinitesimally small in all 6 of these countries. And again, if somebody's putting out false information, are all 6 countries putting out false information? Have the 6 countries conspired together to put out false information? Yeah.
Why is that? I mean, the bottom line.
We're going to get there.
Okay.
We're going to get there. That's what we're about here. Yeah.
$1,000,000 question.
Okay, and that's the paper I published. And I looked at the data again in preparation for this conference, okay? It hasn't changed all that much. The graph looks pretty much the same. This is data just a couple days ago. Again, the United States is a lot closer to Italy and Spain now. And now you're starting to see just a little blip. Okay, it's not 0.3 anymore in the African countries. Its average is about 2.5 per million in all the African countries, but it's in the hundreds in the Western countries. So it's still several hundred times worse in the industrialized West than in these countries. So it hasn't changed much at all. Now, this is just another graph saying the same thing. What I did in this graph, I changed the scale so you could actually see the other countries a little bit. And if you'll notice, the United States is literally way off the scale. It wouldn't go just to the ceiling. It would go to about the 4th story of this building if that scale was extended all the way out to see where the United States data is. And again, in the African countries, it's about 2.5, and ours is 438 when I measured it. So around 450, some people have said. So we see the best outcomes. What are the best practices? How'd they get there? And the answer, I believe, and if someone's got a better answer, fine, let them come up with a better answer. I think the answer is this. The hypothesis is this, is coronavirus always starts in a country because the country is seeded by visitors from outside the country. We know it started in Wuhan, China. It spread maybe to the West Coast from China. It spread to New York and the East Coast from China through Europe, and basically came from Europe. They did some DNA testing and found that out, that most of our cases in New York came from Europe. And they studied where all these flights came from, and there was really never any doubt that all these cases were seeded. People brought the infections in from other countries. They did a study at Hopkins, and it's interesting. Hopkins used their publicly available data, just like I did. And they studied and found out that there was a whole bunch of seeding, they thought, from travelers from other countries went to Africa. And if you look back at the articles that were published in March in that time frame, everyone thought it was going to be absolutely catastrophic in Africa. Everyone thought it was going to be far worse. And that's what we think about disease. If you have less money, if you have more poverty, if you have crowded conditions, if you have minorities, all those things lead supposedly to the disease skyrocketing. And yet all these African countries had all those characteristics, and their numbers are so much lower. So even though the experts from Hopkins Public Health said there were all these flights going in, and we think there was all this seeding going on, again, that didn't materialize in terms of deaths in these countries. And we know that also people came from China. People came from Europe. People have been coming to Africa from Europe forever. We had this thing called colonialism. Anybody remember that? People from Europe been going to Africa back and forth for a couple hundred years. But they've been going from China as well. So there's estimated to be 850,000 patients from China to Africa per year, and most of them go through Ethiopia, but a lot of other countries as well. The picture on the upper left is some kind of ceremonial picture. I believe it's in Kenya, and it's China Southern Airlines, and just kind of celebrating how we have these flights from China. And a couple quotes. Africa was believed to be at risk of severe coronavirus infection because 2 million Chinese nationals live and work in Africa. And then up here, because of steady traffic to and from China, experts worry that the epidemic could overrun already strained health systems. So all the so-called experts were saying there was going to be just this catastrophic infection in China, and it was going to hit China worse than anyone else. This picture on the lower right is an actual photograph from February 26, 2020. That was, you may not remember the dates exactly. President Trump halted flights from China at the end of January 31st. So this is almost a month later. This flight came in full of Chinese folks from China into Nairobi. And the reason I knew that is because I was planning to fly to Nairobi a week later. And this caused a huge uproar among the Kenyan people, and they immediately took it to the Kenyan Supreme Court and got a ruling to stop flights from China after this flight on the 26th. So my point about this stuff is people were coming from China to Africa. They would have been expected to have this seeding process going on, and yet we still don't see these deaths. What's different? What's different about people coming to New York as opposed to people coming to Africa? And the difference is almost 100% of those people that go to sub-Saharan Africa are taking anti-malarial prophylaxis. They're taking hydroxychloroquine or a newer cousin of hydroxychloroquine. They're taking one of these anti-malarial drugs to go to sub-Saharan Africa. People that are traveling to New York are not taking those drugs. And so what I believe you see, is what we call a crossover effect. And Dr. Emanuel began to introduce this just based on her past and her history. She has a personal history and a family history that goes back and involves malaria in her home country and stuff like that. And she knew of these drugs, and she's kind of alluded to the same thing that we're talking about right now. So the World Health Organization and the CDC recommend prophylaxis to all travelers to sub-Saharan Africa. So you think, well, do they do it? Do they really do it? And it turns out, yeah, they probably do. And again, this is just a CDC recommendation, okay? And it turns out that 20 years ago, they did a study in the Journal of Malaria, and they found that 95% of the people going to these countries aren't taking their drugs like they're supposed to. It may have slipped a little bit, but it's probably still something in the realm of 90%. Okay, so we know that the disease originated in China. We know that it's transferred from one country to another by seeding. We know that the people going into sub-Saharan Africa are taking hydroxychloroquine or a similar drug. And so it is believed that this massive disparity rate in these deaths is due to the fact that these countries just weren't seeded like other countries were, that the people traveling in just simply were not carrying the coronavirus in. They're still going to they'll probably go up, they'll get some person-to-person transmission, but I don't think there's a better explanation, and that's the point of this talk is. And if somebody has a better explanation, fine, bring it forth. If someone has a better idea, let's study it. So this evidence strongly suggests that sub-Saharan Africa's best practice, even if it was unintended, was that these people didn't get coronavirus because of the crossover effect. And so the challenge is, if we want better outcomes, so the best evidence we have is the best outcomes are produced by the best practice of treating with hydroxychloroquine. And so my challenge is, that's what the future holds. We don't know what the future holds, but I would challenge our scientific community, the scientists that are leading this country, I would challenge them to study this information and explain this information. And if they don't like this hypothesis that it was due to hydroxychloroquine like drugs, then let them explain it, let them give us an alternative.
Great.